LVCT is a Kenyan NGO that really focuses on HIV testing, HIV prevention, care and treatment programs, and gender and reproductive health. And we have been at the forefront of doing a lot of the HIV testing and counseling work in Kenya and beyond. So we're known for providing a lot of technical support for Kenya, for government, for other countries to scale up the testing and counseling programs. And the way we do our work is that we use research to inform policy and practice, and we have managed to live through that. And out of about 22 studies we've carried out, 11 have given us positive policy outcomes that are actually tangible. So we hope to use REACHOUT to do the same thing, that whatever we get here has to then be scaled up. And for that reason, we work very closely with government, and they are the government team that does community strategies involved in REACHOUT as part of the country advisory group, and are useful in giving us a lot of information so that at the end of it, the whole policy interventions can start right from the beginning up to the end of the project. The close to community providers in Kenya they're a wide variety, but the government itself has a policy and a guideline on the community strategy. That's the policy, and that's what it's called since 2005. And the providers listed within that are known as community health workers, who are a cadre of, let's say, untrained, unskilled providers who are trained for about 2 weeks on different topics. So they'll cover maternal health, child health, reproductive health issues. So they'll cover the broad spectrum of health, but address all the factors, so including HIV, TB, and touch each of it very briefly. We also have the community health extension workers, who are actually health providers based in the facility, but supposed to be doing community work or linking, or they're the ones who the community health workers, the ones who supervise the community health workers. So that's the main one that is recognized by government. So what has happened is that the community health workers are unpaid, they are volunteers, but recently there was a directive that they should be paid about $25 per month for their time they spend in the community. It's not full-time, it's just the part as to cover their volunteering time. We then have different NGOs or different programs which have paid, they train the community health workers on different components. So it's that basic cadre that then gets an additional training. So you can have HIV programs, TB programs, reproductive health programs, providing additional training. Then they'll have their health workers and pay them and retain them in the system for a longer time. But the priority we have in REACHOUT is a lot about what LVCT does as an organization. Our focus is on HIV services, and specifically HIV testing and counseling. And so the focus is, how do you integrate HIV within the community strategy as it exists? One of the gaps has been that in that guideline as it exists, it's very thin or very slim on HIV services. So we always have to have additional training, additional providers, and pay them. We also have our, what we call the HTC providers, HIV testing and counseling providers, who are a trained cadre working within the community. In fact, for that case, they would fall within the CTC providers there. And they specifically do testing and counseling. And we recognize that since they are community-based workers, they need to be recognized as a cadre among the community, the close to community providers, and that HIV needs to be a service that is integrated within the community strategy. And so what we want to do with REACHOUT is define how is that integration of HIV within the community strategy, what is the human resource required to allow that integration to happen, and what quality assurance mechanisms can we put into the community strategy as it is, or as it is morphing. It's currently undergoing some changes, but we have to have quality assurance standards. That means the tools, the guidelines, the processes being defined, supervision structures and mechanisms, and the whole reporting lens being addressed. So we've done a lot of that in HIV, and we hope that the lessons will be then spread over to the community strategy. I think REACHOUT is very exciting, very new, very different. There's been a lot done around community work and close to community providers in the world, but there's still a lot of gaps. One thing that is happening in Kenya is the community strategy is being revised, but we still require a lot of evidence to inform that revision. This becomes one of those studies that helps to do that. REACHOUT already has capacity building as a strong component within it. I think it's a very exciting aspect, and now that it is well defined, it means that we all have to think through how is the capacity of researchers being built, of policymakers, of providers. LVCT is benefiting directly, the government is going to benefit, and our providers are going to benefit, so that at the end of the day we have built the capacity of close to community providers and the studies and the research on that to be able to inform the policy and practice. We keep saying that in Kenya we are very good at policy making and not implementing. We hope that REACHOUT will make a difference in that, because we will be implementing whatever we discover on the way as we go along and provide evidence for doing that. A multi-country study, it means that I'm learning from all the other countries about their context, my context, and thinking through in the bigger picture instead of always thinking from a very narrow lens. Now we are forced to think widely and gain and find our differences and commonalities, and what can we share, what can we learn. I think that aspect is very important. I also think that the element of communications in REACHOUT is very good, and having a communication strategy right from the beginning. For me, and from where I come from, that's definitely one thing that we're taking out. We realize we don't document as well or as much, or we wait for big things to document. Yet you can document from the most basic issue to the biggest one, so that by the end of the project, we have this whole document, or we've documented every process that others can use to build on their work and improve on. So for me, those are some of the best practices that REACHOUT really has.